Good morning, everyone, and today's topic is agents used in cardiac arrhythmias. And cardiac arrhythmias are a common problem in clinical practice and occur in the patients treated with digitalis or anesthetized patients and also patients with myocardial infarction. Arrhythmias may require treatment because rhythms are too rapid, too slow, or asynchronous, and all these can reduce cardiac output. Some arrhythmias can precipitate more serious or even lethal disturbances. For example, early premature ventricular depolarization can precipitate ventricular fibrillation. In such patients, arrhythmic drugs may be life-saving. On the other hand, the hazards of arrhythmic of anti-arrhythmic drugs, and in particular the fact that they can precipitate lethal arrhythmias in some patients, has led to a re-evaluation of their relative risk and benefits. In general, treatment of asymptomatic or minimally symptomatic arrhythmias should be avoided for this reason. Arrhythmias can be treated with the drugs discussed later and with the non-pharmacologic therapies such as pacemakers, cardioversions, catheter ablation, and surgery. Uh, and The electrical impulse that triggers a normal cardiac contraction originates at ventricular intervals in the sinoatrial node. So it's here. And usually at a frequency between 16 to 100 beats per minute. This impulse spreads rapidly through the atria and enters the atrioventricular node. That is normally the only conduction pathway between the atria and ventricles. Conduction through the atrioventricular node is slow, requiring about 0.15 seconds, and this delay provides time for atrial contraction to propel blood into the ventricles. And the impulse then propagates over the His-Purkinje system and invades all parts of the ventricles, beginning with the endocardial surface near the apex and ending with the epicardial surface at the base of the heart. Ventricular activation is complete in less than uh, 0.1 seconds. Therefore, contraction of all of the ventricular muscle is normally synchronous and hemodynamically effective. Arrhythmias consist of cardiac depolarization that deviate from the above description in one or more aspects. There is an abnormality in the size of origin of the impulse, its rare or regularly, or its conduction. The transmembrane potential of cardiac cells is determined by the concentrations of several ions, chiefly sodium, potassium, calcium, and chloride, on either side of the membrane and the permeability of the membrane to each ion. These water-soluble ions are unable to freely diffuse across the lipid cell membrane in response to the electrical and concentration gradients. They require aqueous channels. Thus, ions move across cell membranes in response to the gradients only at specific times during the cardiac cycle, when these ion channels are open. The movements of the ions produce currents that form the basis of the cardiac action potential. Individual channels are relatively ion-specific, and the flux of ions through them is controlled by gates. Each type of channel has its own type of gate, like sodium, calcium, and potassium channels are each thought to have two types of gates. The channels primarily responsible for the cardiac action potential are opened and closed by voltage changes across the cell membrane. That is, they are voltage sensitive. Most are also modulated by ion concentrations and metabolic conditions, and some potassium channels are primarily ligand rather than voltage gated. All the ionic currents that are currently thought to contribute to the cardiac action potential are shown here. And at rest, most cells are not significantly permeable to sodium, but at the start of each action potential they become quite permeable. In electrophysiologic terms, the conductance of the fast sodium channels suddenly increases in response to a depolarizing stimulus. So this depolarization will increase the inward current of the sodium channels. Similarly, calcium enters and potassium leaves the cell with each action potential. Therefore, in addition to ion channels, the cell must have mechanisms to maintain stable transmembrane ionic conditions by establishing and maintaining ion gradients. The most important of these active mechanisms is the sodium pump, sodium-potassium ATPase, and this pump and other active ion carriers contribute indirectly to the transmembrane potential by maintaining the gradients necessary for diffusion through channels. In addition, some pumps and exchangers produce net current flow and hence are termed electrogenic. When the cardiac cell membrane becomes permeable to a specific ion, movement of that ion across the cell membrane is determined by the Ohm's law. That is, current is equal to voltage divided by resistance, or current equal voltage multiplied by conductance. Conductance is determined by the properties of the individual ion channel protein. The voltage term is the difference between the actual membrane potential and the reversal potential for that ion. For example, in the case of sodium in a cardiac cell at rest, there is a substantial concentration gradient and an electrical gradient that would drive sodium into cells. Sodium does not enter the cell at rest because sodium channels are closed. When sodium channels open, the very large influx of sodium accounts for phase zero depolarization of the action potential. So this is phase zero. The situation for potassium in the resting cardiac cell is quite different. Here, the concentration gradient would drive the ion out of the cell, but the electrical gradient will drive it in. That is, the inward gradient is in equilibrium with the outward gradient. In fact, certain potassium channels are open in the resting cell, but little current flows through them because of this balance. The equilibrium or reversal potential for ions is determined by the Nernst equation. The raising extracellular potassium makes the uh, reverse potential uh, less negative. When this occurs, the membrane depolarizes until the new reverse potential is reached. Uh, Thus, extracellular potassium concentration and invert rectifier channel function are the major factors determining the membrane potential of the resting cardiac cell. The conditions are required for application of the Nernst equation are approximated at the peak of the overshoot using sodium concentrations and during rest using potassium concentrations. Those are non-pacemaker cardiac cells. If the permeability is significant for both potassium and sodium, the Nernst equation is not a good predictor of membrane potential, but the Boltzmann-Hodgkin-Cross equation may be used. In pacemaker cells, spontaneous depolarization occurs during the diastole phase of 4. This depolarization results from a gradual increase of depolarizing current through special hyperpolarization activated ion channels in pacemaker cells. The effect of changing extracellular potassium is more complex in a pacemaker cell than it is in a non-pacemaker cell because the effect on permeability to potassium is much more important in a pacemaker. In a pacemaker, especially an ectopic one, the end result of the increase in extracellular potassium is usually too slow or stop the pacemaker. Conversely, hypokalemia often facilitates ectopic pacemakers. In normal atrial, Purkinje and ventricular cells, the action potential upstroke phase 0 is dependent on sodium current. From a functional point of view, it is convenient to describe the behavior of the sodium current in terms of three channel states. The cardiac sodium channel protein has been cloned, and it is now recognized that these channel states actually represent different protein conformations. In addition, regions of the protein that confer specific behaviors such as voltage sensing, or formation and inactivation are now being identified. The gates described below and uh, here in this picture um, represent such regions. Depolarization to the threshold voltage currents in opening of the activation gates M of sodium channels if the inactivation gates of these channels that are H gates have not already closed, the channels are now open or activated, and sodium permeability is markedly increased. So this is actually activated. So these M gates are open and H gates are not closed. And that greatly exceeding the permeability for any other Extracellular sodium therefore diffuses down its electrochemical gradient into the uh, uh, cell, and the membrane potential very rapidly approaches the sodium equilibrium potential. So this is equilibrium is about plus 17 millivolts, and this intense sodium current is very brief because opening of the M gates upon depolarization is promptly followed by closure of the H gates. That is leads to the inactivation of the sodium channels. So sodium channels are inactivated. At most, calcium channels become activated and inactivated in what appears to be the same way as sodium channels, but in the case of the most common type of the cardiac calcium channel, that is L-type, the transitions occur more slowly and at more positive potentials. The action potential plateau phase 1 and 2, phase 1 and 2 here, reflects the turning off of the most of the sodium current and waxing and waning of calcium current, and the slow development of repolarization potassium current. Final repolarization phase 3 of the action potential results in from completion of sodium and calcium channel inactivation and the growth of potassium permeability, so that the membrane potential once again is approaches the potassium equilibrium potential. The major potassium current involved in phase 3 repolarization include a rapidly activating potassium current and a slowly activating potassium. These two potassium currents are sometimes discussed together as activated current. It is noteworthy that a different potassium current, distinct from the potassium activating current and fast, rapidly activating and slowly activating current, may control repolarization in sinoatrial nodal cells. This explains why some drugs that block either rapid or slow potassium inactivating current may prolong repolarization in Purkinje and ventricular cells, but have little effect on sinoatrial nodal repolarization. A key factor in the pathophysiology of arrhythmias and the action of antiarrhythmic drugs is the relation between the resting potential of a cell and the action potential that can be evoked in it. Because the inactivation gates of sodium channels in the resting potential are close over the potential range -75 to -55 millivolts, fewer sodium channels are available for diffusion of sodium ions when an action potential is evoked from a resting potential of -60 millivolts than when it's evoked from a resting potential of -80 millivolts. Important consequences of the reduction in peak sodium permeability include reduced maximum upstroke, called maximum velocity, and reduced action potential amplitude, reduced excitability, and reduced conduction velocity. During the plateau of action potential, most sodium channels are inactivated. Upon repolarization, recovery from inactivation takes place, uh, making the channels again available for excitation. The time between phase 0 and sufficient recovery of sodium channels in phase 3 to permit a new propagated response to an external stimulus is the refractory period. Changes in, refractoriness are determined by either altered recovery from inactivation or altered action potential duration, can be important in the genesis or suppression of certain arrhythmias. Another important effect of less negative resting potential is prolongation of this recovery time. As shown here, the propagation of recovery time is reflected in an increase in the effective refractory period. So that is this period. A brief sudden depolarizing stimulus where the caused by a propagating ion action potential or by an external electrode arrangement causes the opening of large numbers of activation gates before a significant number of inactivation gates can close. In contrast, slow reduction of the resting potential, whether brought about by hypokalemia, sodium pump blockade, or ischemic cell damage, results in depressed sodium currents during the upstrokes of action potentials. Depolarization of the resting potential to levels positive to minus 55 mV abolishes sodium currents since all sodium channels are inactivated. However, such severely depolarized cells have been found to support special action potentials under circumstances that increase calcium permeability or decrease potassium permeability. These slow responses, slow upstroke velocity and slow conduction, depend on the calcium inverse current and constitute the normal electrical activity in the sinoatrial and atrial ventricular nodes, since these tissues have a normal resting potential in the range of minus 50 to minus 70 millivolts. Slow responses may also be important for certain arrhythmias. Modern techniques of molecular biology and electrophysiology can identify multiple subtypes of calcium and potassium channels. One way in which such subtypes may differ is in sensitivity to drug effects. So drugs targeting specific channel types may be developed in the future. Many factors can precipitate or exacerbate arrhythmias: ischemia, hypoxia, acidosis or alkalosis, electrolyte abnormalities, excessive catecholamine exposure, autonomic influences, drug toxicity, for example, digitalis or anti-arrhythmic drugs, overstretching of cardiac fibers, and the presence of scarred or otherwise diseased tissue. However, all arrhythmias result from disturbances in impulse formation, disturbances in impulse conduction, or both. The interval between depolarization of a pacemaker cell is the sum of the duration of the action potential and the duration of the diastolic interval. Shortening of either duration results in an increase in the pacemaker rate. The more important of the two diastolic intervals is determined primarily by the slope of phase 4 depolarization, that is pacemaker potential. Vagal discharge and beta receptor blocking drugs slow normal pacemaker rate by reducing the phase 4 slope. Acetylcholine also makes the maximum diastolic uh, potential more negative. Acceleration of pacemaker discharge is often brought about by increasing phase 4 depolarization slope, which can be caused by hypokalemia, beta-adrenergic receptor stimulation, positive chronotropic drugs, fiber stretch, acidosis, and partial depolarization by currents of injury. Latent pacemakers that show slow phase 4 depolarizations even under normal conditions, for example some Purkinje fibers, are particularly prone to acceleration by the above mechanisms. However, all cardiac cells, including normally uh, quiescent atrial and ventricular cells, may show repetitive pacemaker activity when depolarized under appropriate conditions, especially if hypokalemia is also present. After depolarizations are transient depolarizations that interrupt phase 3, that is early after depolarizations, or phase 4 that is delayed after depolarizations, and early after depolarizations are usually exacerbated at slow heart rates and are thought to contribute to the development of long QT-related arrhythmias. Uh, Delayed after depolarizations, on the other hand, often occur when intracellular calcium is increased. They are exacerbated by fast heart rates and are thought to be responsible for some arrhythmias related to digitalis excess, to catecholamines, and to myocardial ischemia. Severely depressed conduction may result in simple block, for example atrioventricular nodal block or bundle branch block. Because parasympathetic control of atrioventricular conduction is significant, partial atrioventricular block is sometimes relieved by atropine. Another common abnormality of conduction is re-entry, known as circus movement, in which one impulse re-enters and excites areas of the heart more than once. So, like for example, because of this block, the path of the re-entering impulse may be confined to very small areas, for example, within only the atrioventricular node, or it may involve large portions of the atrial or ventricular walls. Some forms of re-entry are strictly anatomically determined, for example, in Wolff of Parkinson-White syndrome, the re-entry occurs uh, in atrial tissue, the atrioventricular node, ventricular tissue, and uh, an accessory atrioventricular connection, bundle of Kent, that is a bypass tract. In other cases, for example, atrial or ventricular fibrillation, multiple re-entry occurs determined by the varying properties of the cardiac tissue may amend through the heart in apparently random paths. The circulating impulse often gives off daughter impulses that can spread to the rest of the heart depending on how many round trips through the pathway the re-entrant impulse makes before dying out. The arrhythmia may be manifest as one or few extra beats or as a sustained tachycardia. For re-entry to occur, three conditions must coexist, as indicated uh, here. Uh, then uh, there must be an obstacle that is anatomic or physiological. uh, to a homogeneous condition, thus establishing a circuit around which the reentrant wavefront can propagate. There must be unidirectional block at some point in the circuit, that is, conduction must die out in one direction but continue in opposite direction. So there is no conduction in this direction but continues in the opposite direction. Uh, and conduction time around the circuit must be long enough that the retrograde impulse does not enter refractory tissue as it travels around the obstacle. So this is the obstacle and this is the travel. That is, the conduction time must exceed the effective refractory period. It is important to note that reentry depends on conduction that has been depressed by some critical amount, usually a result of injury or ischemia. If conduction velocity is too slow, bidirectional block rather than unidirectional block occurs. If the reentering impulse is too weak, conduction may fail, or the impulse may arrive so late that it collides with the next regular impulse. On the other hand, if conduction is too rapid, for example almost normal, bidirectional conduction rather than unidirectional block will occur. Even in the presence of unidirectional block, if the impulse travels around the obstacle too rapidly, it will reach tissue that is still refractory. Representative electrocardiograms may be seen here. So, and also here. Slowing of conduction may be due to depression of sodium current, depression of calcium current, or both. Drugs that abolish reentry usually work by the uh, further slowing depression conduction by blocking the sodium or calcium current and causing bidirectional block. In theory, accelerating conduction by increasing sodium or calcium current would also be effective, but only under unusual circumstances does this mechanism explain the action of any available drug. Lengthening or shortening of the refractory period may also make reentry less likely. The longer the refractory period in tissue near the site of block, the greater the chance that the tissue will still be refractory when reentry is attempted. Thus, increased dispersion of refractoriness is one contributor to reentry, and drugs may suppress arrhythmias by reducing such depression. Arrhythmias are caused by abnormal pacemaker activity or abnormal impulse propagation. Thus, the aim of therapy of the arrhythmias is to reduce ectopic pacemaker activity and modify conduction or refractoriness in reentry circuits to disable circuit movement. The major pharmacologic mechanisms currently available for accomplishing these goals are sodium channel blockers, blockade of sympathetic autonomic effects in the heart, propagation of the effective refractory period, and calcium channel blockade. Antiarrhythmic drugs decrease the automaticity of ectopic pacemakers more than that of the sinoatrial node. They also reduce conduction and excitability and increase the refractory period to a greater extent in depolarizing tissue than in normally polarized tissue. This is accomplished chiefly by selectively blocking the sodium or calcium channels of depolarized cells. Therapeutically useful channel blocking drugs bind relatively to the uh, 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 activated channels, uh, for example during phase 0, or inactivated channels, for example during phase 2, but bind poorly or not at all to rested channels. Therefore, these drugs block electrical activity when there is a fast tachycardia, manual channel activations and inactivations per unit time, or when there is significant loss of resting potential, like many inactivated channels during rest. This type of drug action is often described as use-dependent or state-dependent. That is, channels that are being used frequently or in an inactivated state are more susceptible to block. Channels in normal cells that become blocked by a drug during normal activation-inactivation cycles will rapidly lose the drug from the receptors during the resting potential of the cycle. Channels in myocardium that is chronically depolarized recover from block very slowly, if at all. In cells with the normal optimicity, most of these drugs reduce phase 4 slow by blocking either sodium or calcium channels, thereby reducing the ratio of sodium or calcium permeability to potassium permeability. As a result, the membrane potential during phase 4 stabilizes closer to the potassium equilibrium potential. In addition, some agents may increase the threshold by making it more positive. Beta-adrenergic receptor blocking drugs indirectly reduce the phase 4 slope by blocking the positive chronotropic action of norepinephrine in the heart. In reactive arrhythmias, which depend on critically depressed conduction, most antiarrhythmic agents slow conduction further by one or both of two mechanisms. First, steady-state reduction in the number of available unblocked channels, which reduces the excitatory currents to a level below that required for propagation, and uh, and also by uh, uh, a prolongation of recovery time of the channels are still able to reach the rested and available state, which increases the effective refractory period. As a result, early extrasystolics are unable to propagate at all. Later impulses propagate more slowly and are subject to bidirectional conduction block. By this mechanism, antiarrhythmic drugs can suppress ectopic automaticity and abnormal conduction occurring in depolarizing cells, rendering them electrically silent, while minimally affecting the electrical activity in normally depolarized parts of the heart. However, as dosage is increased, these agents also depress conduction in normal tissue, eventually resulting in drug-induced arrhythmias. Therefore, a drug concentration that is therapeutic under the initial circumstances of treatment may become pro-arrhythmic during fast heart rates because of more development of block. Acidosis, that is slow recovery from block for most drugs, hypokalemia, or ischemia. So I think that is all for today. Thank you for your attention and see you next week. Bye bye.